Hi, good afternoon. Welcome to Good Samaritan Facebook Live. As you can see, I do not have Dr. Stein here with me. We are changing up the schedule as had been announced. Happy to announce that we are not talking about COVID every week, but now taking the opportunity to transition to other very important topics, other aspects of care being delivered at Good Samaritan. And this month being Stroke Awareness Month, have some special guests around our telestroke program that would like to introduce. So next to me, not on screen, next to me in person is Erica Watts, our stroke coordinator for Good Samaritan. And then on the screen in between us, you can see we have Dr. Michael Haboobi. He is a teleneurologist with the University of Louisville, whom we work very closely with. So Erica, maybe speak a little bit about your role as stroke coordinator,
Yes.
And then Dr. Haboobi will have you do the same.
So, hi everyone. So my name is Erica and I'm the stroke coordinator. So one of the roles that I have is actually working closely with our teleneurologists. We work also with obviously our staff and making sure that we have the processes in place so whenever someone does come into the hospital, we can work efficiently to take care of them since stroke care is very time sensitive.
Sure.
Mm-hmm.
And I'm an assistant professor at the University of Louisville. I've been in practice now for almost 9 years, which is incredible to think about. But one of the great advances that we've seen is that we can provide stroke care to people further away. It's not just you have to come to Louisville, but we can actually provide care in the community and close to your home. And that's important nationwide. I did work with the American Academy of Neurology and had lunch with a guy who was one of 4 neurologists for the state of Wyoming. Wyoming's a lot of ground, and they only have 4 neurologists for the entire state. So we can help provide more of an impact. Stroke's extremely important. It's an area that it used to be the 3rd leading cause of death in the country back when I started practicing. And last year it was the 6th leading cause of death. So it's a story that we've actually had some good news on. And hopefully we'll be able to continue on with that.
Well, thank you. And as you mentioned, with stroke, timing being very, very important in this aspect. So from a community standpoint, what should our community look for themselves if they're having certain symptoms, or if they are with a group and they notice somebody having symptoms that would say seek care now, and then what should they do?
Right. So the acronym that we use or is commonly used is FAST. So F stands for facial drooping, A is for arm weakness, S is for slurred speech, and T is for time, and that is to come to the hospital immediately once those symptoms have started.
Okay. And that's something that on our social media page we'll be posting a PDF poster of that as well, that everybody can reference, as that's very important and certainly that time sensitive. So whether it is call 911 or if you're very close to the hospital, getting to the emergency department. And once in the emergency department, that assessment starts from a patient standpoint. And then Dr. Haboobi, that's where you come into play and on screen. And what's your role in that piece?
Absolutely. So as soon as someone detects that stroke is a possibility, we're called right away. And we help to direct what imaging needs to be done. And usually that's going to involve getting a CAT scan, a CT scan of the brain, to make sure that there's no bleeding in the brain. Out of strokes, there are about 800,000 strokes in the U.S. per year, and 87% of them are due to a blockage. 13% are due to bleeding. And so we want to make sure that there's no blood in the brain. The second thing that we're going to usually look at is the blood vessels. And we look at everything from the aorta, which is that big artery that comes off of the heart. So everything from the top of the aorta, the arteries in the neck, the arteries in the head, we're going to take a look at that and see if we can find a blockage there, because that'll help direct what the next treatment is going to be. After the initial imaging is done, I will be on the robot that you see here. And then with the help of the nurses, we can do a very thorough exam, a quick but thorough exam, to help determine, is this a stroke? And if we feel it is a stroke, the next step is, what treatments can we give? You know, I always tell people that when it comes to stroke, my role is threefold. Number one is save the brain cells. Number two is, why did it happen? And we usually worry about that not immediately, but in the days or two to follow that. And then the third part is getting you back to normal, or as close to normal as you can get. And that's going to be with the rehabilitation process. But in the saving the brain cells, a lot of that's going to be, are you a candidate for the clotbuster drug, TPA? And that's been a miraculous drug that has been available now for quite a few years, about 25 years or so. It's really been in common usage. And if you are a candidate for that drug, it can help to break the clot up, restore blood flow to the brain, and prevent, in some cases, prevent any damage from having occurred. So that's part of the reason why time is so critical. In a large vessel blockage, if it's the carotid artery, or if it's the big artery in the brain, the middle cerebral artery, 1.9 million brain cells die every minute. So getting to the hospital is so critically important. If we make sure you are a candidate, and then getting you that medicine to help prevent damage from occurring.
And we've talked a lot about time and treatment. And so when we talk about time, just kind of putting that into an actual number, as a primary stroke center accredited by Joint Commission, we have some standards that we adhere to and have, you know, the best outcomes for the patient. So when we're talking about time, what time frame are we speaking about?
Yeah. So what I always tell people is, if you are able to get to the hospital within 1 hour of a stroke starting, the TPA is miraculous. It does an incredible job of opening that blood vessel up. If you get there within 2 hours, it does a really good job of opening that blood vessel up. Within 3 hours, it does an okay job, but there might be some damage that has already occurred. And if it's more than 4.5 hours, the chances of the medicine helping, actually at that point, after more than 4.5 hours, it's probably going to hurt more than help. So we really want to emphasize any signs of stroke, get to the hospital as soon as possible. And don't try to drive yourself. Call 911, because they can actually call ahead to the emergency room so people are aware, and we can get everything set up for when you arrive.
And part of that call 911, as that primary stroke center, we coordinate with our local EMS, regional EMS, so they know where to bring patients for stroke care. Because outside of Good Samaritan, I believe we were talking that the next closest certified stroke center would be an hour plus away. And certainly when you're saying from start of symptoms, be getting evaluated and treated within 60 minutes. If you have a 60-minute drive to a stroke center, that's not going to be feasible, and that time is really important. Now with our 2 units that we have here that you connect with patients on, we have one that is in the emergency department for certainly as patients present, and working with our emergency physicians, but we have another unit as well.
Yes, so the second one is then located in the ICU. So when a patient arrives to the ER, they will see this robot and possibly see Dr. Habubi. Yeah. And then once they're admitted to the floor, they continue with their care, and then we round on patients every day until they're discharged. And so then we use a second robot, which is a little bit smaller, but then, like I said, it's located in the ICU, so that if there are any changes, neuro changes, we have access to get that robot in the room and they could see that patient immediately.
Yeah, excellent. And probably worth mentioning, you are a real person in Louisville, not a robot. So that
is correct. Yes,
you're not working 24/7, 365, but you work with a team that is available for stroke patients at any and all time. So when you interact with patients on the medical floor, maybe talk a little bit about how you interact and make that as personable and an interaction between physician and a patient as possible.
Absolutely. One of my favorite questions to ask is, what do you enjoy to do for fun? And I love that question for a couple of reasons. Number one, I want to hear about their life and about their story. To do that, I need to know about them. I got into medicine because I love working with people and helping them to get better. So if someone's interested in baseball, I can talk baseball all day with them. If they're interested in basketball, here in Kentucky, of course, big basketball state. But if they're interested in talking about, gardening, I know nothing about gardening. I can't help keep a plant alive if my life depended on it. But I want to hear about what their interests are. And at the same time, when they're talking, I can help evaluate how is their speech. Is it slurred? Are they having trouble getting words out? Are they having, is their face drooping? So I can learn a lot about what's going on from a disease standpoint just by listening to someone tell me about themselves. And also, whatever they're interested in, it helps build that relationship with the patients as well. And it's also, as I said, it's why I got into medicine, to work with people.
And you can maneuver around a little bit as well, too, correct? You can.
Absolutely. So this robot here, I can move the camera up and down. I can turn from side to side, and then also I can zoom in as well. And so this allows to get a really good exam where I can actually, behind where the camera is located, there's a welcome internal medicine residence sign, and I can zoom in on, I can see all the photographs of these young people here. So I can actually look at someone's pupils.
Which, by the way, means that your sight is better than ours sitting here, because we can't make out all those faces.
You can't.
Yeah. And it's amazing how when I started doing telemedicine as a resident, the technology has advanced so much over the last 10 years that before I could see a blur. And now I can actually make out great resolution, which, as you said, is better than, being there in person. And that's a really neat advantage. There are some things I can't do. I can't, I can't feel the tone in someone's arm, but the nurses can. I can't hit someone with a reflex hammer, but the nurses can. But a lot of the exam I am able to do, and we also have other things as well. We've got some pictures that I can put up here. This is the famous cookie jar scene. Where we will ask people to see, what do they see in this photograph? Do they only see half of it? Are they neglecting half the world? So there are a lot of other things that we can do, a lot of neat gadgets that we can add as well.
Very impressive. And you mentioned the the physical assessment piece of it, the nursing team has went through training on how to interact with our telestroke team and what they need, and we have protocols in place to support our physicians, and maybe speak a little bit about how that works and getting the information into our electronic medical records so that they have that piece of the puzzle as well.
So they actually have access to our same electronic medical record. So we use Epic, so they therefore have Epic access as well. So from a nursing point of view, we really just work together. Like you said, we did have training, and we're going through the cranial nerves from the face to the shoulders, and we really work from as a normal head to toe assessment with them. And then when you work enough with them, you kind of figure out what they're going to ask for. But actually working with them, I can then hone in on my own assessment skills. And because when it comes to neurology, it can get confusing and even a little bit difficult, and having practice with them, I feel more confident with those skills. And I see that also with our ER staff and our ICU staff. I mean, everyone on the floor that has worked with them.
Yeah. Excellent.
I think that the nurses, and it was just Nurses Week not too long ago, they are absolute superstars, and they're the eyes and the ears in the hospital. They're with the patients so much more than any physician is. And so if there is a problem, I feel that because they've seen our exam and they've worked with us, they're better able to detect if there is something that's not quite right, and then they can give us a call. We're always available 24 hours a day, 7 days a week. So I think that does give them a little bit of a leg up in helping to detect, is something not right?
Right. Well, certainly I have appreciated this program and being able to deliver care to our region at Good Samaritan that otherwise we would not be able to, and patients would have to leave for stroke care and neurology care that is now being, we're bringing the doctor to them through this technology and training up our team to be able to provide the same level of care that would be provided in a larger academic teaching type of setting. So any closing comments before we see if there's questions?
Absolutely. So I just wanted to talk about the signs and symptoms one more time. So the acronym of FAST, sometimes people will say be fast, which the B is for balance, the E is for eyes or vision. But if you have any sudden balance problems, any sudden vision trouble where you can't see out of one eye or you're seeing double, any sudden facial drooping, any sudden arm weakness, have them hold their arms up and see does their arm start to drift down or start to fall down. Any sudden speech trouble, either getting words out or trouble understanding. It's as if they're speaking another language. Then time to call 911, get to the hospital as soon as possible. It's always better to be told this is not a stroke, this is something else, this is a false alarm. That's fantastic. But if it is a stroke, then we are able to then start the process of helping. And then in the hospital, a lot of times people ask, how long will I be in the hospital for? And it depends. Not every stroke is the same. Sometimes people will have what's called a TIA, which is a transient ischemic attack. It's a warning of something happened. It was going to be a stroke, but then that blockage got opened up again. The oxygen was restored to the brain. And we still treat that as a serious event because what caused that could happen again. It could be a bigger stroke. It could be a bigger event the next time. So we want to know about it and start the treatment for preventing that from happening. So if something happens and it's only for, 10, 15 minutes, we still want to see you. That's still an important event. And then usually, after our workup is done, the looking at the heart, looking at some of the blood work to see how, and that's actually an important thing. I'll come back to that in a second. But with a TIA, a lot of times they're going to be out of the hospital the next day. They're there for 24 hours, get a bunch of tests done, and then they're going home. If it is a larger stroke, they may need some rehab after their hospital stay. And there is a acute rehab facility at Vincennes and Good Samaritan. What acute rehab is 3 to 4 hours of aggressive therapy a day to help retrain the brain. In a stroke, those brain cells die, and those brain cells don't get regenerated. So what we need is for the healthy parts of the brain to pick up the slack for the areas that are injured. And so that's where the therapist, the physical therapist, the occupational therapist, the speech therapist, they help to retrain the brain so that the healthy areas can pick up the slack and help restore function as best as possible. Sometimes people need subacute rehab. And what that is for people who can't physically do 3 to 4 hours of therapy a day. They can maybe only do 1 hour of therapy a day, and that's usually in a nursing home type setting. They'll have a wing for some rehab, and that can be done in a facility like that. Other times people are doing really well and they just need outpatient therapy, in which case that's great. They're safe at home. They just need to go get some therapy as an outpatient. And then sometimes people are just doing so well they don't need any rehab afterwards. But they still should follow up with a neurologist to help learn about what's the latest advancements in medicine. So in Vincennes, there are 2 neurologists that people will usually follow up with, Dr. Pigeon and Dr. Maddock, so they will help to prevent that next stroke from happening as an outpatient.
Yeah, those are great points. And as we talked about the primary stroke certification for the hospital, our acute rehab facility also has a stroke certification through their accrediting body. And then our 2 neurologists that are on staff really allow us to provide stroke care from that sudden onset of symptoms to the emergency room, our telestroke team that we partner with, if rehab is needed, all the way through to ambulatory care in the outpatient setting. And community hospitals such as ours that are putting this into place and becoming primary stroke centers are why we are seeing that stroke leading cause of death being third and moving down, because it is all about how fast can we respond and get the right treatments set up and moving forward.
One other thing I also wanted to mention is, how do we prevent stroke and the main risk factors for it? And there are 5 big risk factors, some of which are preventable, some of which are not, some of which are manageable. The biggest risk factor is age. As people get older, you're more likely to have a stroke. I don't know any way to prevent getting older. I'm trying. If anyone knows, please let me know. We'll go into business together. But as people get older, the risk does go up. Number 2 is going to be blood pressure. Getting your blood pressure under good control is extremely important. Mortality from stroke has been decreasing from the 1970s on, and that's really because of the advancement of blood pressure medications. People should be checking their blood pressure once a day, every other day. I encourage people to write it down in a journal, and that way you can see how the blood pressure is going over time. And if their blood pressure, and again, for every patient, it's going to be a little bit different, but in general, we want the blood pressure to be less than 130 for the top number, less than 90 for the bottom number. And if it's consistently above that, you should be having a conversation with your primary care doctor to help get that under control. Other things like cholesterol can be checked in blood work. If you have diabetes, checking the sugar level. And then the one that most people have the most control over is going to be smoking. If you smoke, strongly encourage you. Now is a great time to quit smoking. Take the money that you'll save, go on a nice vacation. And I think it's good to have, a reward for yourself to say, you know, if I'm going to do this, what am I getting out of it besides for better health and cleaner blood vessels, but also, you know, do something nice, whether it's go on a vacation or buy something that you've always wanted to buy. You know, that can be a good thing as well.
Well, excellent.
Yeah.
Closing comments, anything additional?
So in October 30th, we will have our Be Fast 5K fundraiser. We are raising money to help because obviously with stroke, obviously not everyone's going to have the same results. Some may need equipment, others may not. But we are going to have this fundraiser to help assist those that may need some supplies when they go home. So
Absolutely.
so that's on October 30th. And to register, you can go to www.gsh.org/BeFast5K to register.
Okay. And Be Fast is the acronym. You
Yes.
don't have to be fast
No.
to do
No.
the 5K. That's good.
Yes. So we have a 5K, and then there's also a 1 mile walk/run.
Okay. Perfect. All right. Well, thank you both. Obviously, a lot of great information for our community and increasing that awareness so that they can do their part in identifying symptoms and respond quickly. At this, we don't have any questions, so we're very, very thorough. Again, thank you both for everything that you're doing. Certainly, we know that it's having an impact in our community and ultimately saving lives, and that's what we show up to do every day.
Thank you.
My pleasure. Thank you.
Thank you.
All right, thank you everyone, and we will be back on Facebook Live, I believe, in 2 weeks with a new topic. Thank you.